Myocardial Infarction (MI) by Amjad Ali BS, N, RN. Myocardial infarction (MI) is defined as a condition which is caused by reduced blood flow in a coronary artery due to atherosclerosis and occlusion by an embolus or thrombus which cause damage to the heart muscles. It is used synonymously with coronary occlusion and heart attack. Myocardial infarction occurs as a result of prolonged myocardial ischemia that leads to irreversible injury and necrosis of myocardial tissue because of inadequate blood supply. Myocardial infarction refers to a dynamic process by which one or more region of the heart experiences a severe and prolonged decrease in oxygen supply because of insufficient coronary blood flow. Subsequently, necrosis or death occurs to myocardial tissues. Etiology and risk factors. The causes of MI primarily stems from the vascular system. 1. Vasospasm. This is the sudden constriction or narrowing of the coronary artery. 2. Decreased oxygen supply. The decrease in oxygen supply occurs from acute blood loss, anemia, or low blood pressure. 3. Increased demand for oxygen. A rapid heart rate, thyrotoxicosis, or ingestion of cocaine causes an increase in the demand for oxygen. Age, sex, family history, atherosclerosis, smoking, DM, dyslipidemias, obesity, sedentary lifestyle, mental stress, hypertension. Degree, zone of damages in MI. 1. Zone of necrosis, A. Extensive and complete oxygen deprivation, B. Irreversible damage zone. 2. Zone of injury, A. Area surrounding necrosis, B. Inflamed and injured but viable. 3. Zone of ischemia, A. Surrounding injury area, B. Not endangered and viable. Classification of MI. Pathologically, there are two patterns of MI. 1. Saint segment elevated MI, STEMI. 2. Non-street segment elevated MI, NSTEMI. Clinical manifestations. Some of the patients have prodromal symptoms or a previous diagnosis of CAD, but about half report no previous symptoms. Chest pain. This is the cardinal symptom of MI. Persistent and crushing substernal pain that may radiate to the left arm, jaw, neck, or shoulder blades. Pain is usually described as heavy, squeezing, or crushing and may persist for 12 hours or more. Shortness of breath. Because of increased oxygen demand and a decrease in the supply of oxygen, shortness of breath occurs. Tachycardia and tachypnea. To compensate for the decreased oxygen supply, the heart rate and respiratory rate speed up. Catecholamine responses. The patient may experience such as coolness in extremities, perspiration, anxiety, and restlessness. Fever. Unusually occurs at the onset of MI, but a low-grade temperature elevation may develop during the next few days. Profuse sweating, nausea, vomiting, restlessness, dyspnea, palpitation, severe weakness, dizziness, syncope. 3. Of acute MI. 1. Ischemia, temporary interruption of blood supply to the myocardial tissue but does not cause cells death, T-wave inversion. 2. Injury, prolonged blood supply interruption, causing cell injury, St segment elevation. 3. Infarction, complete cessation of blood supply to cell, cause cell death, necrosis, pathologic Q-wave. Diagnostic evaluations. The diagnosis of MI is generally based on the presenting symptoms. ECG. Saint elevation signifying ischemia, peaked upright or inverted T-wave indicating injury, development of Q-wave signifying prolonged ischemia or necrosis. CKMB, appears in the serum in 4 to 8 hours, peaks between 12 and 24 hours, and returns to normal levels in about 3 to 4 days. Serial samplings are performed every 4 to 6 hours for the first 24 to 48 hours after the onset of symptoms. Chest X-ray, to look for the cardiac size by cardiothoracic ratio, center, pulmonary edema, echocardiography, echo, it reveals segmental wall motion, which indicate ischemia or prior MI. LDH. Elevates within 8 to 24 hours, peaks within 72 to 144 hours, and may take as long as 14 days to return to normal. Troponin. Troponin T and troponin I. Troponin I levels rise after 3 hours, peak at 14 to 18 hours, and remain elevated for 7 to 14 days. Troponin T levels rise in 3 to 5 hours and remain elevated for 10 to 14 days. Magnetic resonance imaging (MRI, ESR), CBC exercise stress test (ABGS), PT-APTT serum electrolytes lipid profile RFTS coronary angiography. CMPLICATION. Severe arrhythmias, recurrent infarction, congestive heart failure, hypotension, cardiogenic shock, ventricular wall rupture, aneurysm, pulmonary embolism, psychological disorders, i.e. depression, pericarditis. Prevention. A healthy lifestyle could help prevent the development of ME. Exercise. Exercising at least thrice a week could help lower cholesterol levels that cause vasoconstriction of the blood vessels. Balanced diet. Fruits, vegetables, meat and fish should be incorporated in the patient's daily diet to ensure that he or she gets the right amount of nutrients he or she needs. Smoking cessation. Nicotine causes vasoconstriction, which can increase the pressure of the blood and result in ME. Treatment and management. There are 3 modalities of ME management: 1. Drug therapy. 2. PTCA, percutaneous transluminal coronary angioplasty. 3. Surgery, CABG. 1. Drug therapy, ACS protocol, oxygen, morphine with antiemetic, nitroglycerin, aspirin 300 mg, clopidogrel 300 mg. Mona, morphine, oxygen, nitrate, aspirin. Other drugs: beta blocker reduces oxygen demand and afterload, anxiolytic ACE inhibitors reduces afterload, analgesics, CA channel blocker, anticoagulant, thrombolytic, fibrinolytics. 2. PCI, reperfusion therapy, primary PCI method to unblock the artery without surgery, ballooning and placing stents, bare metal, and drug-eluting. 3. Surgery, CABG, new route bypass, is creating a round section of block artery. Rehabilitation, lifestyle modification. Stop smoking. Emotional, mental stress. Maintain balance weight. Control DM. Balanced diet. Control over dyslipidemias. Control HTN. Education. Emotional, mental stress. Exercise. Nursing management. Nursing diagnosis. 1. Acute chest pain related to tissue ischemia evidenced by restlessness. 2. Ineffective cardiac tissue perfusion related to reduced blood flow due to atherosclerosis as evidenced by SOB and hypoxia. 3. Activity intolerance related to imbalance between myocardial oxygen supply and demand. 4. Anxiety related to threat of death evidenced by fearful attitude. 5. Risk for ineffective peripheral tissue perfusion related to decreased cardiac output. 6. Risk for impaired gas exchange related to left ventricular failure. 7. Decreased cardiac output related to ineffective contractility as evidenced by painting. 8. Risk for excess fluid volume related to decreased organ perfusion. 9. Deficient knowledge related to lack of information. 10. Deficient knowledge related to about post-ME self-care. Nursing intervention. Administer oxygen. Attach cardiac monitor. Obtain 12 leads ECG. Insert 2 large bore cannula. Take blood sample once for all lab test. Administer medication as prescribed. Check skin temperature and peripheral pulses frequently to monitor tissue perfusion. Ensure rest. Monitor intake-output. Allow the patient and family to express anxiety and fear. Develop therapeutic nurse relationship. Document the events. Provide information in an honest and supportive manner. Thank you. Subscribe.